Hello and welcome to Exercise Rehab 2. My name is Dr. Andrew Craig, and this is our second lecture of the semester. The topic for today will be a review of rehabilitation concepts, and this is going to be a very wide, overarching lecture. We're gonna touch on a number of topics that we'll probably dive into a lot deeper throughout the semester. But a lot of this should be review for you. You'll notice we're going to go through a lot of definitions. We're going to go through a few concepts that will be helpful for you. But next week we will start into looking at uh, regionally specific focus when we look at the low back.
The itinerary for today, we're going to talk first about some terminology with regards to exercise rehabilitation, just so that we're all on the same page, talking about reps and sets and those sorts of things. Then we're going to talk about a biomechanical principle within exercise rehab, specifically the force velocity relationship. If you've taken clinical biomechanics with me, then I've talked to you about this ad nauseum, so I apologize in advance, but it's very important to understand for the concentric and eccentric relationship. Then we're going to look at some anatomy, and we'll talk about the different types of joints within the body and the different types of limitations that they impose on our potential range of motion and how they allow us to move and interact with our environment. This will sort of play into a discussion about stability versus mobility, which is very important within my practice as a chiropractor. We will talk about what makes up a good, quote unquote, good rehab, what sort of principles you should be following. And this will play on sort of 7 principles of rehab that are important for you to integrate when you are creating any sort of plan for an individual with musculoskeletal injury, and when considering specific comorbidities or complicating factors. We will touch on, as I said, the 7 principles of rehab. We'll talk about what goals you should have when dealing with individuals, patients, and clients when setting goals for a rehab program. I will introduce you to the concepts of chronicity, so acute, subacute, and chronic, and we'll discuss the differences in those terms. We will talk about various contraindications, and I will define that term for you if you are unfamiliar with it. And we'll talk about different types of flags that you need to be aware of when dealing with patients that can really complicate recovery. And so they often, if you identify these types of flags, they often force you to sort of pivot your rehab strategy. And then we'll finish up with a discussion about the phases of rehab. So there are 4 phases of rehab that correspond to the phases of recovery. And we will chat about the 3 R's of rehab. Starting with a few different terms, these shouldn't be news to anybody, but we'll talk about repetition, sets, frequency, duration, and volume. These are classic strength and conditioning terms. Hopefully you're familiar with these now that you're in an upper level class of kinesiology. But repetitions just discusses just outlines the amount of times that you're going to perform a movement at one time. So if you're doing 10 repetitions, you may do that 3 times throughout your exercise, and that's going to be the number of sets. So it's sets refers to the number of cycles of an exercise that you perform. And so if you're doing, let's say you're doing bench press and you're doing 5 by 5, you're doing 5 repetitions, you're doing it 5 sets of 5 repetitions. The frequency talks about how often you are exercising. Okay. And this can be a measure of time in regards to the amount of times you work out, say in a week or a month or a year. You can kind of manipulate that or change that depending on your periodization and what you're trying to achieve. If it's endurance, strength, atrophy, there's all sorts of different periodization models that you can use. Duration is another measure of time, and it can be sort of in regards to the length of your workout. It can also be in regards to how long you hold a movement, for a more sort of micro measurement. So for example, the duration of your workout could be 1 hour, but you're actually holding, let's say, a plank for 30 seconds. So what's the duration of the activity that you're doing? But it's also what is the duration of your workout. Lastly, volume is a measure of the total amount of work that you have performed. So this usually includes all of the above variables that we discussed. So for an endurance athlete, this might be a measure of the time and the distance ran for that day. For a strength athlete, it might involve sort of the reps and the sets. So it's really a measure of work, and it's sort of an overall measure of how much exercise you've done overall. These terms are less concerned with the actual exercises that you performed, and they're more concerned with the outcome of your rehab program. So we've got prognosis, natural history, and outcome measures. The prognosis, this is what people are going to come to you and look for your professional opinion on what is the expected course of the disease or the condition. When can I expect to be better? Okay. If somebody sprains their ankle, they're going to come to you and they're going to want to know, is this going to be better in a week? Or is this going to take me 12 weeks to rehab this, right? And it's your job as the professional to know, listen, this is the standard prognosis for a ankle inversion sprain or an ATFL sprain grade 2 would be X amount of time. If you do your rehab, we can reduce that to say, let's say the prognosis is 8 weeks. We can reduce that to say 4 to 6 weeks, get you back to activity. But if you're not doing your exercise, and if you have all these other predisposing factors, say previous history of ankle injuries, sort of if they have any sort of concerns about engaging in physical activity, that can prolong the prognosis and make the prognosis a little bit worse. So instead of 8 weeks, it might be 10 weeks or 12 weeks. Natural history refers to the prognosis if you did absolutely nothing. Okay. If you didn't do any rehabilitation, when would this injury be better? That's essentially what natural history looks at. And now natural history can refer to full recovery. It can also refer to partial recovery. A great example in my profession as a chiropractor is there's natural history for mechanical low back pain or non-specific low back pain. Now, the natural history, let's say it's anywhere from 4 to 8 weeks, depending on activity levels, if they're a smoker, if there is a factor of obesity, if they're exercising, if they have a sedentary job, all those things work into the natural history. The idea with therapy and treatment and rehab is that you can reduce the length of that prognosis, and you can sort of narrow the recovery time to be better than the natural history. Outcome measures, these are very important for providing objective measurements as the person is progressing in their treatment or in their rehab. Okay, this outcome measures measure the effect of an intervention. They can be applied at the start, the middle, and the end of a rehab program in order to sort of gauge progress. So when you apply an outcome measure at the start, you're looking at what's our baseline measurement that we're looking to improve upon. Okay. So let's say you apply an outcome measure like the Oswestry Low Back Disability Index. Okay. You're going to learn that in our, I believe next week when we talk about the low back, but it's a measure of disability due to low back pain. If you apply this at the start of your treatment or at the start of your rehab program, and they have a high level of disability, 4 or 6 weeks later, if they've stuck diligently to their rehab program, you should see a reduction in the level of disability. Okay. And so this outcome measure is something you can apply to show, look, you're actually making great strides in your rehab. You scored a 46 on the Oswestry, which showed a very high degree of disability related to your low back pain. That was 4 to 6 weeks ago. You just finished it today and you're actually only scored a 12. So we've reduced your disability about 3 categories and you're doing much better. Okay. So outcome measures are a tool that's used to create an objective score or an objective measurement of something that might be more subjective. Okay. And so again, it can be used to gauge the severity of condition initially. And then it can also be used to gauge the success of an intervention as you're applying it over time. These terms, I'm almost certain that you've come across as well as kinesiology students, but we'll review them very briefly. So isometric contraction, this refers to a muscle contraction that creates tension without a change in the length of the muscle. So if you were to, I'm sitting at my desk right now, so I grab my coffee cup and I hold it with my elbow at 90 degrees. The bicep is working in an isometric capacity because the joint angle is not moving and the muscle length is not moving. Okay, my bicep is contracting, but it's holding a stable position and there's no change in muscle length. Isotonic, on the other hand, is when you do have a change to the muscle length and you do have a change to the joint angle. Okay, now this can be in a concentric or an eccentric manner. Concentric contractions is when the muscle contracts and you get a shortening of the muscle, and this creates a reduction in the angle between the adjacent bones. So if we're talking about the same example, the bicep that crosses the elbow, a concentric contraction is if you were doing a bicep curl. An eccentric contraction is the exact opposite. So that's when the muscle is actually activating, but it's lengthening, and the angle between the upper arm and the forearm is getting larger at the elbow. Okay, so this is if, let's say, you pick up a dumbbell that's far too heavy, and you're holding it by your shoulder, and your elbow extends to 180 degrees. That would be an eccentric contraction. Isokinetic contractions are a little more complex, and this is when the muscle is contracting and the velocity of the movement is remaining the same. Okay, so this is only done with specific machinery. Very challenging to achieve this sort of in the wild, as they say. An example would be I think it's called the Bioped machine. We have one at Ontario Tech in the labs. And so what it does is it controls for the velocity of the movement. Okay. What this does is allows you to maximally contract against a structure that is changing its force output on you, and it controls the rate of joint angle change. This picture actually I'll make it larger. This is an example of an isokinetic machine, and you can see the individual's leg is attached into this mechanical arm, and that mechanical arm senses the degree change as the person extends their knee. And what happens is it will vary the amount of force that's applying back at the leg to maintain a consistent angle change. Now, I can almost guarantee that you've seen this chart in the past, but we're going to start with sort of a clean canvas because I like to explain this force-velocity relationship as clearly as I can. So let's orient ourselves on this nice clean graph here, okay? So on the vertical axis, you've got force as a measure. Okay, so the amount of force output. So if you are lifting incredibly high amounts of weight, you're exerting a lot of force, it's obviously going to be high on the vertical axis. Along the horizontal axis, we have velocity change in the muscle. The muscle lengthening or shortening. Okay, so it's the change in velocity or speed at which the muscle is lengthening or shortening. In the middle, we have zero. So where the zero is, that indicates if the muscle is not changing length. Okay. So again, our example here would be if you're holding that coffee cup, if we're using our biceps as an example. So if your elbow is at 90 degrees, you are not lengthening it. Okay. And you are not shortening it. Now, if you are holding, let's say, a dumbbell at 90 degrees, so that's zero, and you bring that dumbbell closer to your shoulder, okay, you are shortening that muscle, right? And so the velocity is going to be to the right. If you are holding that dumbbell at 90 degrees and you let your hand drop closer to the ground and the elbow is extending, that's increasing the lengthening velocity. Okay, so this is the force velocity relationship that we are discussing. To sort of drive home the point I just said, isometric contractions are going to happen at this 0 point. Okay, so this is going to represent an isometric maximum. So let's say you're holding a 50-pound dumbbell at 90 degrees. That's your absolute maximum. That's what's represented at this little red dot. Concentric contractions occur on the right side of this graph because there is shortening velocity. So the muscle is shortening, you're bringing that weight closer to your shoulder. If you let that weight extend down to the ground because it's too heavy, that's going to be an eccentric contraction because the velocity of lengthening is increasing. Now, if we look at, so what happens when we go into a concentric contraction? Okay. As the velocity of shortening increases, our ability to produce force actually reduces. Okay. If you've ever been at the gym and you've tried to do things very fast, you might notice that you can't lift as heavy of a weight. Okay. Or as you approach your maximum, so let's say you're doing a bench press. Okay, so to take a different exercise example, if you're doing bench press, you might notice if you're getting close to your maximum, you have to move very, very slowly. Okay, that's because we're actually a lot stronger at shorter or at slower concentric contractions. Okay, so as our concentric contraction slows, we get stronger and stronger, more force output to a maximum point. Once we've hit our maximum point of a concentric contraction, we've reached very, very close to our isometric maximum. So with a concentric contraction, if you can manage to get that bench press bar up, you're likely able to hold it in an isometric means as well. The reverse is true for eccentric contractions. Okay, so eccentric contractions, as the velocity of lengthening increases, our force output increases. Okay. Can anyone venture a guess as to why this is the case? It's probably a question for your physiology professor, but the thought is that with the sliding filament theory, the amount of time to break through those cross bridges that are already formed allows us a lot more strength because those cross bridges are already formed and it takes a lot of force and a lot of energy to actually break them. So we are actually a lot stronger in eccentric contractions than we are in either isometric or concentric contractions. This is the force velocity relationship, and a lot of strength and conditioning coaches and bodybuilders will take advantage of this because you can actually lift and produce a lot more force through eccentric contractions than you can through concentric contractions. And so you'll see people trying to take advantage of this in the gym through eccentric muscle activation, isometric activation. And from a rehab perspective, eccentric work actually targets the tendons a lot more than concentric contractions. So you'll see early stage rehab for tendon injuries will tend to focus on isometric and eccentric. I hope that makes sense to you. If not, please feel free to ask me when we convene in class next week. So just as a quick little review, I want you to take a moment, pause the video, okay? I'm gonna move on rather quickly from this slide, but I want you to pause the video and take a look at some of these words on the slide and try to match them up to the images, okay? So isokinetic, isometric, concentric, eccentric, and isotonic. Which exercises represents each of those? Okay, so pause the slide, kind of draw a little picture, and I've given you the answers on the next slide, but don't cheat. So starting with isokinetic, I kind of already discussed this earlier, but this is the biodex. This is the example of the isokinetic machine that keeps the same velocity of movement. Isotonic is the word that encapsulates both concentric and eccentric. So it's the dark blue line that shows the bicep curl and the bicep sort of eccentric contraction of the same movement. And you can see the green indicates the concentric movement, red is eccentric, and isometric is if you're holding that dumbbell at 90 degrees for the elbow. So let's move on to discuss types of joints and articulations that are found in the body. We're going to breeze over this. This is more anatomy type of discussions, but it's important for you to know and for us to all have a baseline understanding of it. So a joint or articulation, it's an area where two bones meet and they form a connection for the purposes of force transmission or for movement. Okay. This can involve either a large degree of movement or a very small amount of movement. Okay. Examples of something that moves a lot is your shoulder. Examples of something that moves not so much would be, let's say, the sutures of your skull or your sacroiliac joints. Okay. Joints can be classified as either from a structural or from a functional perspective, and we'll discuss each of those over the next couple slides. So the structural classification is based on the structure and what they're made out of. So you've got fibrous joints, cartilaginous joints, and synovial joints. Fibrous joints are when the two adjacent bones are actually connected by fibrous connective tissue. They are very, very stable. Things like the sutures of your skull, that would be an example of a fibrous joint. Cartilaginous joints are actually connected through hyaline cartilage or fibrocartilage. Examples would be where the ribs come around and meet the sternum. That's the costochondral cartilage. That's a great example of a cartilaginous joint. Synovial joints are the ones that we tend to focus most of our attention on in a rehab setting. And this is articulating surfaces of the bones, and they're not directly connected through either fibrous connections or cartilage connections, okay? They tend to come together actually they don't tend to, by definition, synovial joints have a joint cavity or a joint capsule. Within that joint cavity or capsule, you've got this lubricating fluid called the synovial fluid, which is highly important for allowing for smooth movement. It nourishes the joints. It also allows for different pressure changes. Okay, so examples of this would be your knees, your knuckles, the facet joints of your spine, any joint that can have typically a cavitation or that popping sound, that is a synovial joint. From a functional standpoint, so if we're going to classify them based on function, we're talking about the mobility each of the joints have. So we've got a synarthrosis, amphiarthrosis, and a diarthrosis. Synarthrosis these are those immovable, usually fibrous or cartilaginous joints, and they provide a lot of stability and a strong union between bones. This is usually for protection of any sort of underlying soft tissue or for significant force transmission. A good example of this is the sutures of the skull. Amphiarthrosis, these are joints that are slightly more movable, and this includes things like the intervertebral discs, the pubic symphysis, the sacroiliac joint. So they move more than those synarthrotic joints, but less than diarthrotic joints. Diarthrotic joints, or diarthroses, these are freely movable joints, and they include all of the synovial joints. Okay. This is what provides the body with its ability to really move and interact with the environment. And they usually have a larger range of motion than the previous two classification styles. So the knee, the hip, the ankles, these are all diarthrotic joints. And they usually move around 1, 2, 3 axes, and they involve uniaxial, biaxial, or multi-axial joints. Now, there's a lot of crossover between the two classification systems, as you can see in this next slide. So if we're looking at sort of the coronal suture, or any of the sutures of the skull for that matter, they're generally fibrous and they're generally synarthrotic. So they don't move and they have a fibrous connection. If we look at the intervertebral discs of the spine, they're fibrocartilaginous and they're amphiarthrotic. So they have some movement, but it's usually limited and it's usually in one plane. Okay. Then when we move to the more highly mobile joints, like the hip joint in this example, this is a synovial joint. So it's got synovial fluid. There's a joint capsule that surrounds it. And it is diarthrotic. So it's multi-axial, and it can move in all sorts of different ranges. Okay. If you care to learn more about that, you can check your textbook. There's lots of information on these different types of classification systems. So just to sort of recap synovial joints, I kind of ran over it quickly there a couple slides ago, but this is the general example of a synovial joint. So you've got two bones that are coming together. You've got on the inside, you've got synovial fluid. Okay, this is kind of the lubrication within the joint. You've got articular cartilage along each side of the joint that sort of protects the bone and allows for fluid-like movement. Then you've got the synovial membrane that holds in all that synovial fluid, and the articular capsule, which keeps it nice and tightly combined and nice and tightly contained within one space. Now, the synovial fluid is very important to the joint. So it lubricates the joint. It allows for pressure changes when you have compression and decompression of the joint. It's also a major structure that provides nutrition to the articular cartilage. The articular cartilage of bones doesn't have excellent blood supply. So movement of this fluid and circulation of this fluid is actually what allows some nutrition to get to the the surface of that articular cartilage and allows it to stay healthy. Okay, this is where the phrase "motion is lotion" comes from. As you move a joint, you get to circulate that synovial fluid, and that's what allows the joint surfaces to be healthy and can prevent degeneration and degradation of those tissues. There are primarily 6 types of synovial joints that have different functions based on how much sort of stability or mobility is required in certain areas of the body. So we'll go through these briefly, and you can see that they're all contained on the slide on the right here. So pivot joints in the top left, these are joints that allow rotation around a single axis. Good examples of this would be the dens of C2 and C1 articulation. So the first 2 cervical vertebrae, that's an example of a pivot joint. Another one would be the radial head against the ulna, superiorly and inferiorly. So it's rotating in one plane. A hinge joint works more like a door hinge, right? So a great example would be the elbow. It's a single plane joint as well. Then you've got the saddle joint. An example of a saddle joint is at the base of the thumb between the trapezium and the first metacarpal bone. And this allows movement in multiple planes, but it's not all ranges of motion. It's usually in two cardinal planes. Then you've got the plane joint, which is when 2 surfaces come together and allows for a lot of gliding. Good examples of this would be between the carpals and the tarsals in the feet and the carpals in the hands. Then you've got the condyloid joints. This provides movements in multiple planes. One side's usually convex and the other's concave, but it's not quite a ball and socket. So good examples of this would be the radiocarpal joint of the wrist. And then last but not least, you've got the ball and socket joint. And the ball and socket joint, this allows for the absolute greatest degree of range of motion in the body. And there's actually only 2 areas in the body where these joints truly exist. I'll let you think about that if you can name them. Maybe I'll drop that later on today. I won't make you wait. The two areas in the body that have ball and socket joints are the hips and the shoulders. Now, it is also helpful to distinguish the axial and the appendicular spine. So this is sort of a functional classification as well. The axial spine supports the head, the neck, the back, and the chest, and it really does form that vertical axis of the body. Okay. It includes everything that is in sort of the pale colored or the bone colored on this diagram. So it's your skull, your spinal column, including your sacrum and your coccyx, and your ribs and your sternum. The appendicular spine, this is what includes sort of your shoulder girdles, your pelvic girdles, and the limbs. So the way that I think about it is the axial spine, it protects all of the sort of vital organs, and it also maintains a lot of the stability. The appendicular spine, this is what allows us to interact with our environment, allows us to reach and grasp for things, allows us to walk and run and move around the environment. So axial skeleton in general is more for rigid structural support, whereas the appendicular spine is more for interaction with the environment and mobility. Okay, so this is sort of where the ideas of stability versus mobility come into play, and why it's important to sort of compare and contrast between those two ideas. I have a bit of a love and hate relationship with images like this. This sort of this attempts to indicate areas that need to be stable versus mobile. Okay, now one of my biggest pet peeves is it says stable joints and then it just names areas: foot, low back, scapula. Those aren't really joints, but you get the idea. Certain areas do need to be more rigid, and you need to have more stability as their functional goal, whereas other areas need to be more mobile and need to have mobility and high range of motion as their functional goal. So, for example, the foot. In order to push off the ground as you walk or as you propel yourself, you need a stable foot. You need that foot to be a rigid structure to allow you to press off of the ground and to use it as a rigid lever to propel yourself forward, right? On the other hand, your ankle needs to be mobile. You need to be able to dorsiflex and plantar flex to a high degree in order to allow for that sort of that walking pattern. So when you are pushing off the ground, your ankle needs to be very mobile. Your foot needs to be very stable so that you can use it as a rigid lever. Okay, and so on and so forth with the rest of those areas. Now, this is kind of cool because they've used the different color coding system to show you the areas that should be mobile versus stable. And this is, again, in a very general sense. This is also to do with the spinal structure, okay? Because if anyone's had a shoulder injury, you'll know that stability is very important for rehabbing it, okay? The shoulder is an incredible joint. It's got a very high degree of mobility, the highest degree in your whole body. Okay, we use our shoulders for a lot of movement, and because it has such a high degree of mobility, it's not structurally stable from a bone perspective. And we will discuss this when we go through the shoulder in a few weeks. But because it's so mobile from a osseous perspective, it depends on the rotator cuff, the deltoid, the pecs, the lats, the traps, everything that attaches into the humerus to stabilize it. Okay. So, although it does have a lot of mobility from a structural bone perspective, it needs to be stabilized heavily by the muscular components. So, again, at risk of sort of repeating myself, mobility is this concept that the joint has the ability to move through an adequate and expected range of motion of that particular joint. Not all joints are supposed to move a lot. And so, for example, you want to have high mobility in that shoulder joint so that you can throw a ball, climb a rope, all those sorts of things. But you really don't want a ton of mobility through other joints, for example, through the sacroiliac joint, because that's predominantly a load bearing joint. You want forces to be able, high amounts of forces to be able to transmit through that joint. And so you want it to be very stable. Okay. So in certain areas, you want high degrees of mobility. In other areas, you want high degrees of stability and rigidity. Luckily, we have these two systems, the muscular and the osseous or the bone structure, that work together to achieve both of these things. So we use our central nervous system to control those muscles around joints in order to direct forces to produce the required amount of movement. We've also got other structures like ligaments, tendons, joint capsules, all these things that help to provide stability to joints that may be mobile. So it is our being able to move and interact with the environment safely, and in order to put it in perspective with this course, in order to rehab people appropriately, it's a gentle balance between stability and mobility that we want to provide to our clients and to our patients. Okay. Oftentimes, when people have injuries, and let's take sporting injuries, for example, they may have pushed the limits of their mobility. For a perfect example is an ankle sprain. So an inversion sprain, or when you roll your ankle, what you've done is you've taken your ankle, you've put it into a range of motion that is close to its end range, and you've pushed it too far. So what you've done is you've asked that ligament, the ATFL, on the lateral aspect of the ankle, to protect the joint. If your tissue load exceeds the tissue tolerance, you're going to get a tear in that ligament. That's what happens when you push the mobility constraints of that ankle. And so a lot of the rehab will be to provide stability to that ankle. Okay. If we were to boil it down to sort of, one or two Coles notes, some practitioners would say if a joint is moving too much or more than is expected, then you need to stabilize it. You need to teach stabilization techniques to reduce the hypermobility around it. If the joint doesn't move enough, you need to teach stretching. You can use passive mobilization techniques. You're trying to get the joint moving more. Okay. Think about that for a minute. Let that sort of stew, because that's an interesting concept for anybody who does manual therapy. The next thing I want you to think about is, can hypermobility or hypomobility be beneficial? Okay. Hypermobility, if we break this down, hyper means too much. Mobility, we've just discussed ad nauseum. So hypermobility means you move too much compared to what is expected. Hypomobility is the exact opposite. So hypomobility means you don't move as much as you should or as would be expected. My question to you is, are there situations under which hypermobility can be beneficial? And are there other situations where hypomobility might be beneficial? Okay. I want you to think about that, and we will discuss that in class. I just want you to think about why hyper and hypomobility might not always be an issue. If you need a quick break, this might be a good time to do it. Okay, moving right along, we're going to discuss what makes a good rehabilitation program. There are some fundamental principles that you should follow in creating your rehab program. And as you get more comfortable with it, and as you get to know your target population, you can start to tweak some of these strategies. But I want you to know these characteristics, because this is how you're going to start with good habits, and this is how you're going to start with creating diverse but very, very stringent and appropriate exercise rehab programs. So a good rehab program has all of these characteristics. Okay. It's person-centered. You need to think of the person in front of you. It's not, client A with an ankle injury. It's Brandon who rolled his ankle playing basketball. Okay. That individual is going to have their own goals. That individual is going to have their own history of previous ankle injuries. That's going to be really important for you to consider. Your rehab should be specific to that individual and to that functional deficit. So with that ankle injury, you're likely going to have to work with the ankle, yes, the knee, and probably the hip, teach some balance, coordination, control, other aspects that we'll learn throughout the course. But it needs to be specific to that individual and to that injury. It needs to be goal oriented. What sort of short-term and what long-term goals have you thought of, and do they match up with your client or with your patient? It needs to recognize that rehabilitation is a process. There is no magic pill that's just going to make sort of any sort of injury that you're rehabbing go away or get better faster. This is important for you to recognize as the rehab clinician, but it's also important for you to teach this to your client so that they know what to expect. We call it expectation management. And this is how you can avoid those situations where clients and patients think that you're not doing the best job that you could be doing and you're not giving them the most appropriate plans. So expectation management is important. Make sure that they know it's a process. Rehab should be a part of a multimodal approach. So you're working with their physicians, you're working with kinesiologists, you're working with a dietitian, you're working with sleep management, stress management. It's multimodal, meaning there's multiple things that go into rehab. It's not just a mechanical issue. Lastly, it should follow evidence-based criteria and best practice guidelines. The Ontario Kinesiology Association, the Ontario Physiotherapist Association, Chiropractors Association, Massage Association, we all have evidence-based guidelines that we follow. And there's tons and tons of research online. You can look for meta-analyses, you can look for best evidence summaries. These are the great places to start, especially if it's a new condition that maybe you've not had the most experience with. Okay. Now remember, you will be an expert in these areas as a kinesiologist, and you will have all the tools you need to provide these characteristics of a good rehab program. Your textbook outlines 7 rehab principles, and I think it's important to go through these because it's just a little bit more structured than those characteristics. Now, they put it into an acronym that doesn't really make much sense to me. It doesn't say anything. So to me, I've kind of rearranged it to CAT-itis. I think that might be easier for you to remember for exam and for your career purposes. But what this stands for is compliance, avoid aggravation, timing, individualization, think of the total patient, what's the intensity of the rehab, and there should be specific sequencing involved. So think of these sort of principles when you're coming up with your rehab strategies, and we're going to go through these individually. Number 1 is sort of the cardinal rule, and it's even in the Hippocratic Oath for medicine, but basically says do no harm. Okay. This is your primary goal. If you're administering exercise or rehab incorrectly, you could worsen the injury, and that is absolutely contrary to our goals. You could cause further injury, and you can cause negative side effects. So you should start with less intense activity, and you should progress based on the individual's ability. So start low and progress slow. Okay. Let's say the first day you meet someone, you give them exercise and they blow through it, no problem. Great. Guess what? That gives them positive reinforcement that they're doing better than you had anticipated. Okay. The next time you're going to have to restructure your plan. You're going to have to give them some more challenging exercise. And you've probably just taken a couple steps off of your rehab from the beginning to maybe your mid rehab now. Okay. So avoid aggravations as much as possible. The second principle here is timing. Exercise should start immediately. Okay. You need to think about, when are you going to start the rehab? How much? How often? Is it an acute injury, a chronic injury? Realistically, you should start some form of rudimentary exercise as soon as possible. That can be passive range of motion exercise, that can be active exercise depending on their level. All of the research suggests that the faster return to activity results in improved outcomes in all facets of life. It results in improved return to learning, improved return to work, improved recovery, all those sorts of things. The third principle is compliance, and the fourth is individualization. So compliance means that the patient is compliant with completing their exercise, and they're working with you sort of as a team. So otherwise, if this doesn't happen, if there's no compliance, it's not going to work, right? They have to be engaging in their rehab for that rehab to work. And it's your job to sort of empower them to understand the importance and reasons for the programming and the importance and the reasons for engaging in exercise. Okay. The patient must complete all prescribed exercises. They must also make it a habit or a routine, and they need to attend all treatment sessions. Obviously, things happen and things pop up, but if you've prescribed a treatment plan that's twice a week for 6 weeks, and they're only coming in once every other week, they're not going to get the stimulus or the results from your rehab because they're not getting the stimulus that you've sort of planned for. Okay. The fourth one, individualization, suggests that no two individuals are going to respond the same way to the same stimulus or to the same rehab program. You need to think about all the factors that impact their life. So, do they have a good support system? What are their goals? Are they looking to get back to activity? Are they motivated to get back to activity? Do they have any sort of psychological concerns or yellow flags that you need to be aware of? We'll discuss yellow flags in a few minutes. Do they have the baseline strength? And do they have the requirements to actually return to full recovery? Okay. The last three, 5, 6, 7, specific sequencing, intensity, and think about the total patient. You do need to think about the sequencing of your exercises. Obviously, you're not going to do the heavy lifting or a squat or a max deadlift, as the first thing you're doing. You need to have some sort of strategic plan and include progressions along the way. Progressions should build on previous activities, and there should be sequencing in how you have the exercise completed. Probably sprinting without a warm up is not a great idea. Probably, doing some form of loaded squats before unloaded squats isn't a great idea either. So think about how you're introducing the exercises. When we look at intensity, this is going to be highly dependent on the individual and their abilities. Should it be high load? Should it be low load? Should it be more focused towards endurance or strength or just strict recovery or just general engagement in activity? The proper stimulus will promote the proper growth and recovery. And so it's your job to figure out what's the best intensity for that to work. Last but not least, you need to think about the total patient. Okay, the person who comes to see you with an ACL tear, they're not just an quote unquote ACL tear. They're a person with goals. They've got aspirations. Likely, if their ACL is torn, you're going to be dealing with a whole bunch of other structures that support the knee. So you need to target multiple systems. You need to incorporate a variety of techniques and think about the whole person. As we discuss goals for your rehabilitation program, it's important to remember it's multifactorial, and it's not just your goals, it's also the individual's goals. Think about these questions and how you can optimize your goal planning. Speak to your client, find out what their goals are, think about what your goals would be. Do they match? Are they congruent? Are they realistic? Who needs to maybe adjust their expectations a little bit? Do you think the patient's expectations are realistic? Can they achieve that? that's a discussion that you need to have with the individual. So it's a shared process that you need to do between you and your patient or your client. And when you're thinking about how to start exercise, the best, like I said, start low and progress slow in a general sense. Okay. Especially when you first start to interact with somebody after an injury, because you really don't know what their functional goals are. Okay. You're going to put them through sort of physical exam. You're going to talk to them, see what their strengths are. But with rehabilitation, it needs to be a strong enough stimulus that you're actually creating growth. And you need to build confidence. So if they're coming in every day and they're not achieving what you have in store, you're really going to kind of crush their spirit. So there needs to be some sort of confidence boosters along the way. Again, consider the goals of the individual. Okay, are they looking to return to work? If you're working with WSIB claims or Workplace Safety Insurance Board claims, that's going to be a big goal for the insurance company. You need to assess if that's a big goal for the individual, because sometimes those are not congruent, and you as the rehab expert in between need to sort of navigate those muddy waters. Are they looking to return to learn? This happens with a lot of high school and university level athletes. If they're going back to school, uh, this is important for concussions or anything that might prevent them from sitting in a lecture hall for long periods of time. There's also return to play if you're working with teams specifically, and activities of daily living. I find this with older individuals who may have trouble completing their ADLs, or individuals with disabilities who also may need a little bit of hand completing their ADLs. Now, what's their intentions? Do they want to get better? Do they have the capacity to get better? And how can you prevent the reoccurrence of those injuries once you've helped them rehab their experience? Goal setting is a skill, and it takes time to learn. And so I often try to break up my goal setting in long and short-term goals. Long-term goals are that final destination. Are they going to achieve full recovery? Are there performance goals you're looking to achieve? Make sure that you're creating them as specific goals and not general goals. A fine example of that is people always say they want to get stronger or they want to lose weight. Those are incredibly general goals, and there's no actual achievable goal there. You need to have, say, numbers to it. I want to be able to lift 225 pounds, or I want to lose 20 pounds. Like, those are long-term tangible goals that have an actual number to it. Short-term goals is where you can sort of break down your long-term goals into more measurable chunks. This will provide positive reinforcement, allows them to move in the right direction towards their long-term goals. Sometimes you can create short-term goals that aren't, just basic steps towards the long term. Sometimes you have to create sort of chunks and achieve different things. So a prime example would be if you're trying to do an Ironman as a long-term goal, a performance goal, you're obviously going to have to improve your VO2 max while swimming. So you're going to have to do that in different ways. You're just going to be training to try to increase your VO2 max. Now, that's not directly related to completing an Ironman, but it's very indirectly related and will allow you to perform in different areas. So short-term goals are what you should be focused most on in the day-to-day. Long-term goals is what you're focused on when you're creating your periodization or your programming. Hopefully you've all heard of SMART goals. SMART is just an acronym that you should use when you're actually coming up with these short-term goals. So S stands for specific. It should be a specific goal that you're trying to achieve. It should be measurable. That's what the M stands for. You can use outcome measures for this. You can use any sort of number, whether that's number of pitches for a baseball player before they retire the player, or bench press, how much weight, that sort of thing. Achievable, is it achievable by the individual, and realistic? Those two kind of blend together to me. is it realistic for that individual, and is it realistic for that time frame? So timely. You should give yourself a time frame. Obviously, certain goals are achievable over a small time frame. Certain goals are only achievable over a longer time frame. So they need to be very realistic towards what you're trying to achieve. So try to remember this acronym here, okay? Next, we're going to discuss the importance of the flag system in medicine and rehab. There are a number of different types of flags that are important for you to understand, to be able to identify when you're dealing with patients and clients. The flag system is born out of this biopsychosocial approach to managing complex musculoskeletal injuries. It's used to describe psychosocial prognostic factors that can indicate persistent pain and work disability due to musculoskeletal conditions. So what they really are is being able to identify flags in recovery helps you to identify obstacles in their recovery. So what's going to prevent them from achieving maximum recovery? Flags indicate concerns that should be warranted in clinical situations. They're not the same for everybody, and they're quite unique for each individual. And if you can identify flags early, then you can come up with strategies to overcome these flags and to overcome these barriers. A lot of times they require referrals to other professionals. Sometimes you can work through them sort of at the individual client level. And they're really, really interesting. There's a lot of interesting research on flags and how they impact recovery in a rehab setting. So let's talk about the different types of flags. You've got red flags, orange flags, yellow flags, blue flags, and black flags. Red flags are often ruled out through a thorough medical history. Okay, these are medical or biological factors. If you identify red flags, a lot of the time you're going to be making a referral to a specialist or to their medical team or looking for diagnostic imaging. Okay, so red flags indicate a serious medical pathology or a serious medical concern. This will tell you maybe you should not be applying your treatment, or what we call red flags are often a contraindication to certain types of treatments or therapies. So if you identify a red flag, so let's say, for example, let's say you're taking a history on a patient and they have a previous history of kidney cancer. Okay, let's say they have previous history of kidney cancer, and a lot of the symptoms that they're telling you mimic back pain, but they also are very similar to their previous history of the kidney cancer. You need to make sure that's ruled out first and foremost before you start to say, yes, I can help to rehabilitate your back pain through exercise. Okay, so medical red flags are often, they take precedent over anything else. Orange flags are mental health and personality disorders. So things like post-traumatic stress disorder, depression, anxiety, these typically increase the complexity of your case, and they can lead towards more chronic conditions. Yellow flags, I would say, personally in practice and in clinical settings, I always make sure to rule out red flags. Okay, and we'll go over a number of different sort of common red flags depending on the condition. So, for example, with low back pain, there's a number of questions that you should ask: numbness and tingling, bowel and bladder function. Those are sort of red flags for severe disc herniations in the low back, like cauda equina syndrome. But we'll go over those when we talk about low back pain. But often in clinic, I'm ruling out red flags first and foremost. And then once let's say I'm thinking the condition is more musculoskeletal in nature, then I start thinking, okay, what sort of yellow flags are present that might complicate the recovery? Yellow flags are these psychological factors. So patients' perceptions, beliefs, and behaviors. Does the individual demonstrate maybe an exaggerated response to their pain intensity. So they come in and they look like they're joking with you and they're happy, and you ask them what their pain level is on a scale from 0 to 10, and they say, "Oh, doc, it's a 10 out of 10." But that doesn't really match what you're seeing, right? Like a 10 out of 10 is the worst pain you could ever imagine, uh, potentially life-threatening type of pain. Okay. Other yellow flags would be things like if they're highly focused on their pain, if you're palpating and every single point makes them jump and they say it's a 10 out of 10, it's a focus on pain. If the individual has a high perceived amount of disability, if they think that hurt equals harm. You'll notice this with exercise a lot. If you're putting them through rehab exercises and they are reluctant to engage in that exercise because it's a little bit sore, they often think that they're hurting they're harming the tissues when really they're not. Fear avoidance behaviors is another yellow flag, and preferring passive care. Preferring passive care is an interesting one. It's essentially those individuals who you have a very hard time engaging in physical activity. They come to you and you may do some soft tissue work, use interferential current, other modalities, but you have a really, really hard time engaging them in physical activity. That is a yellow flag. And it usually indicates potentially prolonged prognosis. Okay. Blue flags are work and social factors. So these can be, let's say they're off work because of an injury and they don't think their workplace can accommodate them returning to work. This can be sort of a negative influence on them actually getting back to work. Other things can be if they think that, let's say, their coworkers or their supervisors are not very supportive of them engaging in rehab, maybe sort of making fun of them in the background, those sorts of things. And then even if they want to return to work, because that can be a big, big barrier for rehab professionals. Finally, black flags, these are compensation or systematic factors. If there's high financial strain, they're not able to financially afford attending rehab sessions. If there's liability claims and they're trying to maximize the quote unquote disability associated with their injury, that can also negatively impact their recovery. And then if there are some sort of compensation claims that are outstanding, you also have to take that into effect or into consideration. Let's briefly chat about chronicity. And chronic and acute are complex words that often confuse people and make them a little bit nervous, but in reality, they just refer to a timeline. This is important for you to understand. Acute, subacute, and chronic, they're all defined in terms of time, and they're highly related to causation and to a prognosis of an individual. So when somebody attends your office or wants you to assess them and wants to engage in rehab with you, if they're in the acute phase, your goal and what you're trying to do is to prevent that from becoming a chronic injury. Okay. And again, it's just based on time. So acute means any injury that happened within the last 3 months. Okay. There's going to be different types of inflammatory processes happening. There's going to be different amounts of connective tissue developing. There's different growth patterns, vascularization, and nerve disruption is very different for acute versus chronic injuries. Chronic injuries refer to anything that's over 3 months in duration. And a lot of times, chronic injuries can have more psychosocial barriers to recovery. So a lot of those yellow flags that we discussed a couple of slides ago can come into play a lot of times into chronic injury situations. Subacute is just a subclassification of acute. If you're wondering why I skipped over it, subacute is anything from 6 weeks to 3 months. Personally, in my clinic, the way that I sort of document injuries, I always have acute, subacute, or chronic before the condition. That way, as soon as I look at it, I know the duration that they've been experiencing it, and I know what I can expect in that situation. So why do we really care about identifying them as acute, subacute, and chronic? I mentioned one reason, and that's the physiological processes that are happening are very different in each of these phases. It also can relate to prognosis or how well you expect them to recover. The outcomes are often very different for chronic or acute musculoskeletal injuries, and the treatment options are different. Okay, we'll go through that sort of ad nauseum throughout the course. But with acute inflammation, you're going to want to do different things than if something's been bothering someone for, say, 6 months. Okay, those are two very different situations. They should be treated very separate, very differently. So the treatment options are very different. It's also important to know the terminology changes or the terminology differences. So itis, if you see the itis at the end of a word, so tendonitis, itis refers to acute inflammation. Osis refers to chronic inflammation. Okay, so if you see, let's say, patellar tendonitis, that means that there is acute inflammation in the patellar tendon. If you see patellar tendinosis, that suggests there is chronic inflammation in the patellar tendon, tells you it's been there for a lot longer. It's probably a lower grade amount of inflammation, and the treatment strategies will be very different. The last thing we're going to discuss briefly today is contraindications. Okay. Contraindications are situations where certain treatment strategies may not be warranted because they're unsafe, ineffective, or don't have substantial research to support their usage. Okay. Specific procedures may be contraindicated while others may not be. Okay. And we've got two different levels of contraindications. We've got relative and absolute. Relative contraindications, this is when caution should be used if you're going to be applying that therapy. A very, very sort of a very typical example would be if you have a woman who's pregnant and she's got low back pain, you cannot use a TENS machine over the low back. There's a baby in there that's forming. There's a heartbeat that can be impacted by electrical impulses, and TENS is introducing electrical impulses. So you shouldn't be using it on their low back. If they have a shoulder injury or a wrist injury, you may be able to use the TENS with that individual. So it's a relative contraindication to using a TENS unit. Another example would be exercise for an individual with cardiovascular disease or asthma. Okay, just because you have asthma or cardiovascular disease doesn't mean you shouldn't be exercising. It just means you need to be careful with the type of exercise that you are applying. Okay, you're not going to want to get someone with asthma to start to breathe really aggressively, so you're probably not going to be introducing sprint exercises or high intensity training or HIIT training or anything like that, because you're just going to send them into an asthmatic episode. What you do want to do is start to increase their cardiovascular strength through probably aerobic capacity building exercises. So you just need to be careful with the exercises. I like to think of it as relative contraindications. If the benefit outweighs the potential harm in certain situations, that's what you need to think about. Absolute contraindications are different. They're very black and white. If something is absolutely contraindicated, therapy should not be applied under any circumstances, and it must be avoided. A common example for this would be if somebody has instability between their C1 and C2, so their atlas and their axis in their cervical spine. Okay, you should never apply cervical traction to their neck, which means grabbing hold of their head and sort of tractioning or decompressing their spine. What can happen? You can cause severe injury because they have no stability between those two segments. So that is absolutely contraindication indicated. You should not be applying that treatment under any circumstances. The 3 R's of rehabilitation are a good starting point when you're starting to create any sort of rehab plan or program for a patient or an individual. And so it's a logical sequence of steps where when the injury happens, how do we get them back to fully functioning? So the first R is to relieve symptoms. And so this is our goal within sort of the first
few days of an injury. So in sort of a severely acute injury, typically we're left with relieving the symptoms. That's the best thing we can do for the individual. So this often means using modalities, means using pain control techniques, education, so teaching strategies for relieving the pain at home and preventing any sort of further damage. And so relieving symptoms is usually what we're left with in those first few days of an injury. Uh, and it's the best value we can provide as rehab specialists. Then, as the sort of the days go on after an acute injury, we start to move into restoring deficiencies. And so this means deficiencies in range of motion, deficiencies in strength and endurance, and so on and so forth. And so a lot of times we can't start to restore those deficiencies until the individual's out of a significant degree of pain. So they have to be able to move in order to start to clear some of these deficiencies. Once those deficiencies are sufficiently improving, then we can start to look at returning to function. And so function can be highly specific to the individual, and it can mean anything from, an elite sprinter getting back to sprinting the 100-meter dash, or it can just be, construction worker trying to get back to work, or a mom who wants to hold their baby while doing some tasks around the house, anything, right? And so function is highly specific to the individual. And you'll see it varies greatly if you're working with a younger population, a geriatric population, and so on and so forth. So it's kind of just a very short and sweet blueprint for all rehab protocol. And then uh, there's very specific things we can think of within these 3 R's of rehab. Okay, so I want you to know those three. Now, if you've taken any physiology or probably an injury management, you've gone through this in extreme detail, but these are the basics of tissue healing. Obviously, the body's tissues go through a logical sequence of healing processes from a physiological perspective. And so I'm not going to require you to understand the intricacies of this because I think it's more important for maybe a phys or a biophys or injury management class. But I want you to know that there are various physiological processes that are specific to each phase of healing, starting immediately after the injury. Okay, and so that means you have different inflammatory markers, different healing mechanisms, and different rehab goals for each phase of the recovery process. So this is starting with day zero, or kind of, as soon as the injury happens, you get this process called hemostasis. So hemostasis, this is immediately after the injury. It's the quickest, it's the shortest phase. You get blood clot formation, and you start to get some fibrin plugs start to build up. And so that starts to reduce the bleeding, if there is bleeding in an injury, or the bruising or whatnot. And so it's the shortest phase. It usually starts and ends rather quickly. And we're really not doing a ton of rehab in this phase, right? Like people might use their own little home remedies like ice or heat or whatever it may be. And we'll talk about ice and heat later in the course, but they'll use things to try to reduce the immediate blood loss and start to promote that blood clot formation immediately within the first few minutes and hours of an injury. The next phase is the inflammatory phase, and this is where you get excessive pain, edema, loss of function, lost range of motion, all those sorts of things. And so in these early phases, we take a very gentle approach. So from day 0 to day 3, or even honestly up to a week, you're taking a very, very gentle approach, and we're just trying to reduce pain, dysfunction, trying to give them some strategies at home. So it's a very supportive phase. I think a lot of rehab professionals, when they first get out in the field, get too eager to start applying rehab principles, to start applying manual therapy techniques within these first few days. And it's a bit of a learning curve for them because it does actually aggravate symptoms and make things worse sometimes in those first trying days after an injury. So a lot of times taking a very conservative approach is the best way to go about it. After the inflammatory phase, then we get sort of early late proliferation and remodeling phases. And so this is where the tissue starts to strengthen because you've got a lot of collagen and fibrin healing happening. There's less edema. There's less risk of further injury within these phases. And so this is why we progressively load the tissue in the later stages, because it's safer, because the tissue is more resilient, it's stronger than within those early proliferation and inflammatory phases. So, I kind of break it up with hyperacute phases or within those first few days. So that's the hemostatic phase and inflammatory phase. That's hyperacute, just trying to help the person get through some negative feelings and trying to reduce the damage or minimize the damage that can occur. Then within that early proliferation, late proliferation, you're starting to introduce more movement techniques, very gentle. You might do some manual therapy, those sorts of things. And then in the early remodeling and late remodeling, that's where we start to do highly specific exercises that are going to get them back to functioning, right? So you do exercises within the proliferation phases, but a lot of times they're not as functionally derived. So instead of doing something that the individual might do every day, like lifting, say, 50 pounds from the floor to the waist constantly, you might just get them lifting something. It might be 5 pounds, 10 pounds. It might just be getting them to go on an elliptical or a bike. You're just trying to get them moving and back, building up their confidence and building up their ability to move in general. Okay. So I want you to know the basics. I want you to know that you go from stage 1 to 2 to 3 to 4, all the way through that process in the recovery paradigm, or basically the tissue healing paradigm. You do not need to learn like I said, the intricacies of this. You can, if you like. I think they're in it's table 3.1. So this would be chapter 3. This is a really good summary of what happens within each of the phases. So you've got the healing phase here, the timeline in the second column. Then you've got some characteristics, some suggested rehab interventions, and goals for rehab as well. Okay, so again, you don't need to memorize this. Be familiar with the like which one comes first, second, third, fourth, and probably the timeline that they're associated with. So that was the phases of tissue healing. Now we're going to talk about the phases of rehab. Okay, and I want you to understand this quite intuitively. So the phases of rehab, they correspond to the tissue healing phases, but they can be divided into 4 general phases. Each stage typically lasts a different amount of time depending on the severity of the injury, the nature of the injury, and the performance required of the individual post-rehab. But in general, the phases are always the same. Okay, and this is a very good blueprint for any sort of rehab specialist to sort of attack a musculoskeletal injury. And so the phases are inactive phase, active phase, resistive phase, and the advanced phase. Okay, and you can read about these more in your textbook if you like. Each phase will be typically associated with a specific therapeutic interventions and goals that are suggested. And in the early phases, we typically rely more on passive modalities to control spasms, to control edema, to control pain, just give some normalcy back to their life and reduce their discomfort. That's generally what people are looking for in their first few days. You might introduce, very gentle passive movements, but you're generally going to wait until active and resistive phases to start to do that, right? And so we're going to go into these in detail, but inactive means the person's inactive. You're likely going to be asking them to immobilize or not move much. And then you're going to progressively increase that in the active phase. And then you're going to introduce a lot of resistive exercises in the resistive phase. And then the advanced phase is where you introduce a lot of the functional rehab. Each of these phases overlaps with the previous and with the next. Okay, so as you can imagine, like any sort of manual therapy you're doing is going to have overlap within a lot of these phases, and a lot of the exercises will too. You're generally just increasing the difficulty of the exercises, or the progress between the structure of the exercises. So phase 1, the inactive phase, this corresponds to the inflammatory phase. Typically, typically the hemostasis phase is already over by the time you've entered into some sort of rehab advice. And so this is when the injury is highly vulnerable. This is the first few days of the injury. And so generally the person requires rest, inactivity. You're going to focus more on pain relief, trying to control the edema, make sure there's not a pathological amount of swelling in the area. You're going to reduce any sort of muscle spasms, and you're going to try and make the person comfortable. Okay. You really do not want to avoid, or you do not want to cause any aggravation or damage any of the tissues further. So the most typical tools that we use within the inactive phase is things like reassurance, education, pain modalities. If it's necessary, bracing. Um, I will talk to you probably on an in-person lecture about bracing because it can be very, very effective in certain situations, especially in acute phases. But it shouldn't be a long-standing treatment strategy. You might also use some sort of ambulatory aids, so like a walker or a cane, something of that nature. And then ergonomic recommendations if the individual needs to go back to work. Okay. Within the inactive phase, you might not be exercising or doing any movement to the immediate area, but it's very important to maintain function of the adjacent areas. So we talk about looking, you need to look at the region above and below, or the joints above and below. So let's say that a person's come into you and they've injured their elbow. Even if you can't move their elbow, you want to make sure that they are maintaining function of the joints above and below. So, and I'm talking major joints. So the wrist below and the shoulder above. You can start to do some movement to those areas to try to influence a little bit of blood flow and make sure that the muscles are still moving. So that's phase one, the inactive phase. Phase two is the active phase, and this begins when the individual is transitioning from the inflammatory phase into the proliferation phase. Okay. And the primary goal here is to resolve any of the leftover inflammation that's happening and edema that's happening. And you want to transition towards some safe movements that the individual can do at home. Right. So this is where you're doing they might do passive range of motion. You might do active assisted range of motion. You might even be getting into active range of motion as well. You can focus on improving and maximizing the proprioception, range of motion, gait control, balance. You're not going to be doing strength really in this phase, but you might be doing some endurance work. We're really shifting our focus away from just a passive strategy, pain control, towards more of a movement strategy and a rehab strategy. This is an important note to keep in mind when you do start to introduce any sort of resistance exercises. Okay, you want to progress to single plane movement first before you start to challenge a person in multiple planes. Okay, I'll give you a prime example. If let's Okay, so I'm working in a clinic, a patient comes in to see me, they've rolled their ankle and they've got what's called ATFL sprain. So they've sprained their ankle, right? Quite severely, very bruised up. We've gone through the whole rehab process and we're now onto that active phase. And so one of the things I really want to get them into, and so maybe we're into the resistive phase even, but one of the things I want to get them into is running, because this individual plays soccer 3 times a week and wants to get back to it. So before you have the person out on a soccer field, responding to balls, taking passes, making kicks, that's a very uncontrolled environment in multiple planes. What you want to get them to do is you want to get them walking in a straight line first, then maybe jogging in a straight line first. So it's in a single plane of motion. So you start to build up the strength in one plane before you start to introduce multiple planes and have them responding left, right, backwards, that sort of thing. Okay, so take it one plane at a time and kind of move through the exercises that way. So the resistive phase, as you can imagine, is just that next step forward. So after the active phase, they should have nearly normal range of motion. Should be a lot less pain. They might have some pain left over, but you start to stop talking about pain and get away from focusing on that. And so you start to you start to work on those deficiencies that they still have in strength, endurance, and proprioception. So you're quite certain that you're not going to injure the person with a lot of exercise and rehab. So you start to introduce it aggressively within the resistive phase. These exercises, again, should start with the single plane of motion, not multi-directional. And a lot of times, what differentiates the resistive phase from the advanced phase is these exercises might not be exactly functional to what they want to do. Okay. So a good example is, let's say you have a CrossFit athlete who injured their shoulder, and they injured their shoulder doing let's say they were doing clean and jerks. Okay. You're not going to have them doing clean and jerks in the resistive phase, but what you are going to have them doing is some overhead presses. So they're building the strength in the overhead press. And they might also be doing some pulls from the ground. Okay. But split up. So these are exercises that will build their strength and gives them some resistive gives them some resistance to actually build that strength up, but they're not doing the full functional movement. Okay. You hold that full functional movement off until you get to the advanced phase, where you're actually trying to mimic the stresses that they're encountering in their normal activities. So this is where you might start to do some very light clean and jerks kind of thing. Okay. So their mobility, their strength, their endurance should be at or close to normal levels, because you've done all your due diligence and taken time within that resistive phase to build up their strength. And then you can start to focus strictly on function. Okay. This will be performance specific. If it's a hockey player, they're on ice, they're working on that groin injury. If it's a baseball player, they're pitching balls, those sorts of things, right? You're really getting back with a full focus on function. If it's somebody who's a geriatric population and one of their biggest goals is to be able to go up the stairs, you're getting them on the stairs and doing that with them within this phase. This pyramid demonstrates the hierarchy of the rehab approaches that we just discussed. And so on the left-hand side, you'll see the rehab phases. You'll see that it starts with the inactive phase, right, which generally involves an exam and an assessment of the issue, and you come up with some problems and some goals. And then you're going to start to use some strategies to decrease pain and correct some of the deviations. Then you transition into that active phase, and you'll see each of these phases has some crossover within this chart. Then you lead on to the resistive phase, and then at the end, you get the advanced phase, which is focused fully on performance and function, right? And I like this diagram because it shows you how each of those phases corresponds to the phases of tissue healing. So if you're worried you're still within that early proliferation phase or the inflammation phase, maybe that's going to prevent you from being a little bit overzealous and pushing on to the active phase, because you know that they're still in the inflammation phase. You might want to keep them in the inactive. And the final thing I want to bring up is this rehab program continuum. I think it's perfect for this last slide because it really demonstrates the progress of interventions that are appropriate for each phase of rehab. And it kind of summarizes a lot of the things we've talked about today, okay? So you can see across the top, the first row, you've got phase 1, phase 2, phase 3, phase 4. So each of those would correspond to one of the phases of healing as well. And then along the first column here, you've got different types of treatment strategies, right? So you've got modalities, flexibility exercises, resistive exercises, proprioception, and then performance-specific exercises. And you'll see those first two phases are somewhat heavily reliant on reducing pain, essentially, right? So you've got cryotherapy, you've got electrotherapy, which is like TENS and interferential current, you've got soft tissue, you've got joint mobilization, those sorts of things, right? Then when you start to get into the later phases, you start to introduce active assisted range of motion, active range of motion, passive range of motion, and those exercises can be done throughout the next 3 phases with progressively more challenging tasks. Then you can actually start to integrate some resistive exercises, some isometrics, and all the way to isokinetics and diagonal patterning. And then you introduce some proprioception, and finally that early functional and complex functional movements until the end of the advanced phase, right? Sometimes this entire process is stretched out over months or years. Sometimes this is stretched out over, a couple of weeks. Maybe somebody advances from phase 1 to 2 within a couple of days, and then to 2 to 3 within a couple of weeks, and then so on and so forth. So it's very individualized for each person, but the shell or the core of what you should focus on remains the same. So I hope you learned. I hope you learned a little bit today with this rehab review. Thank you for tuning in, and I hope everyone knows who this impressive horse is. The name is Northern Dancer, and was a big horse that came out of Oshawa from E.P. Taylor. Anyway, have a great day, and I will see you in lecture next week.